Okay, we're basically at the time to start our webinar. And good morning, good afternoon, and good evening to all our attendees joining from around the world. Welcome to CCMA Online Uterus Microwave Ablation webinar. And my name is Dong. I'm from the Ecomedical Global Marketing. I'm honored to be your host today. So on behalf of CCMA, I'd like to sincerely thank you all for joining us today. So tonight is our pleasure to have Professor Cheng-Yu Long with us. Professor Long is a world-renowned pioneer gynecologist from Kaohsiung Medical University Hospital, and he is also the director of the OBGY department, and also he is the president of the Taiwan Association of Gynecologic Tumor Ablation. And Professor Long has been engaged in the treatment of gynecological disease for more than 30 years, specializing in minimally invasive and non-invasive treatment of gynecological tumors. So on behalf of CCMA and Ecomedical, I'd like to thank you all for joining us today. So before we begin, a quick reminder, please use the chat box to ask questions through the webinar, and we will have a
Okay.
So without further ado, please join me in welcoming Professor Long about his presentation, the application of microwave ablation for uterine fibrosis and adenomyosis. Yes, Professor Long, please.
Okay. Dear colleague, it's my pleasure to be here and have a talk about the application of microwave ablation for uterine fibroid and adenomyosis. I'm Dr. Long. I'm from the Kaohsiung, Taiwan. Okay. Today we will discuss the progress in our hospital for the microwave ablation. Okay, next. Very good. Next. Okay. Okay. The thermal ablation therapy for uterine fibroid and adenomyosis, such as the radiofrequency and the microwave ablation, are minimal invasive and HIFU surgery is non-invasive treatment with the purpose to achieve the tumor shrinkage through ablation for symptom relief. Next. Recently, more and more women want to preserve their uterus, even they suffer from dysmenorrhea and anemia. Therefore, some less invasive treatment have emerged, such as HIFU, radiofrequency, and microwave ablation. Okay. Next. We have conducted the first laparoscopic microwave ablation surgery in Taiwan on September 2021. Okay. Next. In comparison to HIFU surgery, microwave ablation is suitable for women with adenomyosis with the subserosa myoma or ovarian tumor with concomitant surgery conducted. Laparoscopic exam can also be performed for women with unexplained dysmenorrhea, while microwave ablation with endometrial ablation can be done for women with hypermenorrhea and no fertility desire. Women with broad vertical abdominal scar, which is not candidate for HIFU, can opt for the microwave ablation treatment with the cheaper price. The advantage of non-invasive HIFU surgery, including no scar and no adhesion formation and bleeding. Next. Microwave ablation creates heat with the friction of the water molecules spinning against each other through electromagnetic field. When the antenna is inserted into the uterine fibroid for high-temperature tumor ablation, the antenna can be inserted through percutaneous or transvaginally for safety concern. it's my advice to perform the microwave ablation through laparoscopy and guided with real-time ultrasound to ensure the depth and the location of antenna within the tumor. It is no radioactive exposure and speedy recovery. Next. Let's take a look at the machine. We use the Eco company. You have the FDA and CE approved, right? Okay, next. The selection of the treatment protocol is based on the size of the uterine fibroid. Each ablation mode has different energy output, setting, and the ablation time.
मैं फिर देखूंगा लीजन देख
Okay. The green, okay, oh, okay, next, okay. The green zone is the ablation zone, okay, with width the 3.6 centimeter and the height 4.2 centimeter, including tip distance 0.8 centimeter. In this case, okay, the ablation mode that we selected is a total energy 100 watts with ablation time of 10 minutes. Okay, next. 再按一下。Okay. We conducted the wet lab demonstration by using the pig liver and heart to mimic the uterine fibroid ablation therapy. For ablation result, there was a precise ablation mode, which is a spherical shape and compatible with ablation zone given in the treatment protocol. Next. Almost the same as the treatment protocol. Next. Okay. 下一张。对。Okay. 好。We measure the ablation zone is about 3.1 multiply the 3.5 centimeter when using 100 watt for 3 minutes ablation, which is in accordance with the ablation protocol. When the first coagulation necrosis completed, the needle tip is gradually retracted from deepest to superficial regions. I suggest to eat more grill mochi to improve the skill of ablation. It's helpful for your technique. Next, like this. Okay. 下一张。再来，再按，再一张。Okay. Can we use the ultrasound to evaluate the ablation zone? Obviously, the measurement of the ablation zone is more precise when using the MRI compared to ultrasound. We can see the upper part is done by ultrasound, and the lower part is done by the MRI. It's more clear using the MRI. Okay. 下一张。Okay, like this, it's almost the same. We can see the when you're using the MRI can evaluate the ablation zone the more precise. Okay. We can have the preoperative planning of the ablation route with the assistance of MRI image. So before the surgery, we can make a plan according to the image of MRI. And we need to evaluate both sides. One is the sagittal view, the upper part, and the lower is the transverse view. Next. This is the illustration of the 8 centimeter diameter myoma. Its radius about the 4 the centimeter. We will use the ablation mode with ablation area of the 4.2 and multiply the 3.6 centimeter for twice. Okay, next. Not only sagittal view, but the transverse view of the uterus need to be calculated. For this, for example, this women, because the width over 8 centimeters, so we need to do at least 3 times of operation. We can adjust the insertion site under the guidance of the transvaginal ultrasound. Right side is the transvaginal ultrasound. Next. Here is the microwave ablation study result of our hospital. We just published one paper. Next. I would like to share our preliminary data of the transvaginal ultrasound and the laparoscopic guided microwave ablation for uterine fibroid and adenomyosis, which is just accepted by the GIT in June last month. A total of 20 women. Okay, 20 women were included and divided into myoma and adenomyosis treatment group, pre and post-op. The evaluation including the VAS score and the PBAC, the menstruation bleeding, and the uterine fibroid symptom quality of life questionnaire. There were significant improvement across all primary outcome measures. In terms of the VAS score, the menstrual bleeding amount, and the quality of life after the microwave ablation procedure. Check. So microwave ablation is is a very effective. This is this is the subgroup analysis between myoma and the adenomyosis treatment group. There were significant improvement across all aspects in myoma group compared to adenomyosis group, but both groups have comparable regression rate after 3 months follow-up. In summary, the laparoscopic assisted microwave ablation is an effective treatment for the myoma and adenomyosis. The evidence by notably reduced lesion volume and significant improvement in the quality of life, PBAC and the VAS score. Okay. After because we found after the 20 cases, we adjust the ablation strategy, including preoperative ablation route planning. There were significant improvement in symptom and the ablation rate after the first 20 cases. So we compare the first 20 cases and 20 to 40 cases. We can find the success rate increase from the 50% to 90%. So even if it is a simple procedure, but the learning curve still existing. Okay. It's a case sharing. The 3A, the 38 years old female underwent microwave ablation on the June 30. Bilateral ovarian endometrioma with cul-de-sac adhesion was found during surgery. Anterior wall myoma ablation was performed successfully. However, she developed fever after 40 days with leukocytosis and an elevation of the CRP level, hospitalization for 3 weeks. And we use the antibiotic for at least 2 weeks, and then the fever subside and the discharge. After discharge, she started develop abdominal pain and the expulsion of the necrotic tissue from the uterine cavity. The ablative myoma is The ablated myoma is successfully excreted from the uterine cavity from the ultrasound follow-up. And we can see the middle lower, the ultrasound we can see. And we cannot see the myoma anymore because the myoma already and it's expulsion gradually until all myoma was the was expulsion. Okay. Okay, then we talk about there are three approaches, three ways of the ablation technique, including the laparoscopic-assisted or percutaneous ablation. The first one, which is guided by abdominal or transvaginal ultrasound. We usually use the transvaginal ultrasound as the image is clear with no bowel interference. And second is percutaneous. We call it percutaneous ablation technique, usually guided by abdominal ultrasound, but also can in combination with vaginal ultrasound. The last one is the transvaginal ablation route, which can be performed through the natural orifice, such as the transcervical approach with no skin wound. Okay. Okay. Next. That's then we talk about everyone I know. Everyone like the transcervical microwave ablation most. The patient is placed in low the lysostomy position. An artificial aside is created by infusing the 300 to 500 milliliter of normal saline through the surgery needle via the umbilicus. An introducer is then inserted through cervix to provide the guidance during the needle route insertion with the transabdominal ultrasound guided. When the when the predicted route is confirmed, we will insert the needle to the planned site and ensure the target zone before ablation. 上一张。Oh, no, 下一张。Oh, I need to and introduce my pattern. This long speaker is I invented this. Okay, thank you. Next. Okay, our strategy for transabdominal guided transcervical microwave ablation. For the first, is assessment of the adhesion in the cul-de-sac. And pre-operative, we can see the transvaginal ultrasound, the the sliding sign. We can and then during operation with the artificial the aside, lifting the uterus upward with the dilator can accumulate the fluid in the cul-de-sac. The second, artificial aside can prevention from the thermal bowel injury. And the third, the adequate standing bladder for better view. And the fourth, the planning the order, I suggest from the fundus to service the direction. And we use a moving shot technique rather than fixed electro technique. And the fifth, the monitor with both the sagittal and the transverse view to be a precise operation. And the endometrial ablation in cases without fertility desire. In our experience, we evaluate 100 women with symptomatic adenomyosis and myoma, and 55 women underwent laparoscopic-assisted transvaginal guided microwave ablation, and 45 women underwent the transcervical microwave ablation using the transabdominal guided. And we compare these two groups, we can find the age is almost the same, but the operating time the only half. The only side, the operating side of the nodes transcervical microwave ablation, only half of the laparoscopic microwave ablation. And the post-op, the day one VS score is significantly lower than the laparoscopic microwave ablation group. Okay, then we take a look at our evolution of the nodes, the microwave ablation. We only start using nodes microwave ablation routinely after we have conquered and mastered about ablation technique by performing nearly 100 laparoscopic cases. Then we dare to do the transcervical microwave ablation routinely. Okay, we can let's take a look at the video sharing. When we do the microwave ablation，按一下那个下面有一个，Yeah, okay. When we use the introducer and confirm the predictive route, and then we insert the antenna inside and begin to ablate. After finish the posterior wall, then we adjust the direction upward to the anterior uterine wall. You can see, yeah, very fast. Okay, very easy. But we need to keep a distance between about 1 centimeter away from the serosa surface. Then we take a look at the paper review. The first one is from the China, the study. The 70 women with symptomatic adenomyosis were treated by transvaginal ultrasound and the laparoscopic guided percutaneous microwave ablation. There was a 100% success rate without major complication, and 84% show improvement of dysmenorrhea and 78% improvement of menorrhagia. Okay. This is a study of long-term follow-up of uterine fibroid with the 42 women included. The treatment effect maintained for at least 3 years, and the continuous shrinkage. Okay. Okay. The study was conducted in Japan with microwave ablation. The endometrial ablation plus the transcervical microwave ablation myolysis was done. The average size, the shrinkage of the uterine myoma was 40 to the 68% at the 3 months, and the 37 to the 69% at the 6 months after operation. Transcervical the microwave ablation seems to be practicable as a low invasive treatment for the typical myoma, especially suitable for the posterior wall myoma, I think. Okay. We have finished the 273 cases, the highest volume of microwave ablation in Taiwan. We live in the Kaohsiung. Next. Finally, let's compare the 3 ablation procedures. HIFU is the most expensive and take a longer operating time. And the learning curve is also longest. And ablation range of microwave ablation is most precise. The only radio frequency ablation needs dispensive pad because it has electric current. The only microwave ablation is not affected by tissue impedance due to its high ablation temperature, 100 degrees. The average reduction rate at the 3 months is about 50% for 3 procedures and 70 to 80% at 1 year for microwave ablation and radio frequency ablation. The most common The most common complication for microwave ablation and the radio frequency is increase the vaginal discharge, and the bowel injury may occur in the three procedures. All is impossible. We need to be cautious, although it's a very low percentage. Okay. So the conclusion is the transvaginal guided, the transcervical microwave ablation is the simple, repeatable, precise, and effective procedure for both myoma and adenomyosis, especially suitable for women without other lesion, including the adhesion or ovarian tumor, and women without fertility desire but wants to be preserve uterus can can try this procedure. It's very effective for dysmenorrhea and menorrhagia in the shorter operative and the recovery time, especially for the transcervical, the microwave operation. But it still need the strict patient selection, evaluation, and pre-operative planning. And in summary, let's compare the three procedure again. The first one is laparoscopic microwave ablation using the transvaginal or abdominal guide. It's suitable for women with the fertility desire and with other pelvic regions such as the ovarian tumor or endometriosis. We need to be how to fulgurate the endometriosis lesion. And maybe you need to do the adhesiolysis are highly needed. We can do the laparoscopy procedure. And the second is the percutaneous ablation using the transabdominal or the vaginal guide. The only for huge myoma, or especially in the anterior wall, we can easily insert the antenna into the target zone. And last one is transcervical using transabdominal guided, suitable for women without the fertility desire, without ovarian tumor, and better with, especially in the posterior wall myoma. It's easier to do this transcervical operation. But we got to remember we need to take the three factors into consideration before surgery. First one is the fertility desire. The second is the tumor size. And the third is we need to evaluate the pelvic lesion, such as ovarian tube adhesion, or type 6 or 7 myoma. That is the subserosa myoma. We can take all the three factors into consideration before we planning the treatment protocol. Next. Okay, welcome to Kaohsiung. Thank you so much.
Okay, thank you, Professor Long, for your insightful presentation. And now we move to our Q&A session. Currently, we received some questions in the chat box.
这里哈，
对，
这里
那个
垂直
结束放
放映，
对，
有吗？
Okay, Professor Long, we have the first question from Dr. Guru.
在哪里？
Which
我
antenna
照相
better
了，
for adenomyosis and fibrosis?
照
You mean
No.
which antenna?
Yes.
Which route, right?
Which
哎，
antenna better for adenomyosis and fibrosis? 就是可能真的选择。
真选择，哎，不是一口而已吗？
Maybe from different
I
gauges and
ever do the three brands of the microwave operation using the different brands of the antenna. I wanna know your question is which antenna, which brand or antenna is better for adenomyosis, right?
no, I don't think it's for a different brand. Maybe from different gauge and length of the antenna. 就是
Okay.
直径啊，或者是长度之
Oh,
类
okay,
的。
okay. Oh, it depends. I think the most important is not is unrelated to the adenomyosis or myoma. You need to evaluate is tumor size. So just now I mentioned the three factors. I don't mention the adenomyosis or the uterine fibroid. I just say the tumor size. So we have the different I can show you the different protocol has the different the spherical shape, the short axis and the long axis. So we need to depends on the tumor size. It's most important, not the adeno or the uterine myoma. I'll show you this slide is here. Oh, you can see the tip distance for echo is only the 0.3 centimeter, and the long axis and the short axis like this. We can see the different protocol, different watts, and the different time, different watts, and different time have the different shape of the operation zone. So it depends on the tumor size. Maybe the tumors are very big, like a 10 centimeter. We need to choose the biggest. We can save time. So I think the most important is the tumor size because just now I said the only the microwave operation is not affected by the tissue impedance. So even it's very hard, very solid adenomyosis, we still can use the microwave operation to operate easily. Okay. 对呀，截图，好，圈。Any other?
Okay, we have the second question from Dr. Marcus. He's asking, do we cover patient with antibiotic, perioperative and postoperative?
Yes.
就是为, yeah,
It's
please.
really important, right? Because for the first 20 cases, we do not use the antibiotic routinely, but after just now I reported a case report in the patient with the necrotic tissue syndrome. Maybe we do the operation time too long, and the more the necrotic tissue formation, so have the PID, the pelvic inflammatory disease occurred. So I suggest that we can use the fragile or can use the about the 7 days to prevent the infection.
Okay, thank you. And the next question is from Dr. Anna. She's asking, how do we know the ablation is enough? Maybe maximum time?
好的。
She's asking, how do we know the ablation is enough?
Okay, because we can see we like to use the moving shot like this slide I'll show you. When we insert the deepest zone, and we can see the just now like I'll show you the video more clear. 最后一个这个你把它按下去，那个this one 这个按下去，给它按下去。Okay, you can see when we begin to ablate the myoma, we can see the ablation zone like a spherical shape. And when the ablation not extended anymore, we confirm it's already finished. You can see the other anterior wall begin to ablate. And then when the ablation zone not change, not bigger, we confirm it's this operation zone already finished, and then we moving shot. We can backward about 1 to 1.5 centimeter to begin next. next operation. Don't need to stay the same operation room too long. Easy because when within the learning curve, we do the first 20 cases. We like to stay the target zone at least the 5 to 10 minutes. It's easy to have the necrotic tissue too much. So now we change our protocol. We stay the same operation zone about 1 minute. 1 minute it should be enough. You can see the operation zone not expanded anymore. Okay. Okay.
Okay. So the next
聊天
question，
那边就有
在哪里
动一下，
点一下那个聊天。
啊？OK，
看一下确定往上
啊，
一下，
嗯，对，哦，这么多问题啊。
Okay, so the
OK，
next question is from
嗯，
Professor Mohammed from Pakistan. He's asking, are you using hydrodissection when doing transabdominal ablation?
对，哎，等一下，我看一下哈，
好，
看一下你说，哎，
那个 Professor Mohammed 的提问。
哦，你说穆罕默德问的是不是？
对，他
哦，
在问那个
还是等一下
水隔离的事。对对
啊，
对。
还说hydrodissection, I wanna know. And what do you mean the hydrodissection? Because transabdominal, you mean the percutaneous, right? Percutaneous operation, right?
Yeah, can I
Yeah,
talk?
yeah, yeah,
Yeah, I am Dr. Fayaz from Pakistan. My
yeah,
question is when we are doing trans-abdominal ablation, so
yeah.
can we put say line surrounding the uterus, then visibility would be much better,
Yes.
even under guidance of laparoscope. So that may be quite helpful because we are using in many other parts of the body during ablation. So do you have any experience of hydrodissection during ablation, especially in transabdominal? Because transvaginal, that is not possible.
Do taxation. I just I just do the artificial aside with hydro taxation. Not so. Yeah, I never do that. I just do the percutaneous operation through the abdominal wall, and but I don't the hydrotaxation. I'm I don't what what's the real the meaning of the hydrotaxation
Okay.
of uterus. Okay.
Okay, let me explain. Actually, in hydrodissection, we are putting 5% dextrose in the surrounding of the uterus. Then
Yes.
visibility of the fibroid and visibility of the needle under ultrasound would be
Oh
much
yeah, I
better.
know, I know, I know, I know what you mean. I know. Yeah, really. I know. I now I like to do using the French aid the Foley into the uterine cavity and infuse about 10 milliliter water to extend the endometrium. The uterine cavity, we can clearly see the mucosa, the endometrial range to preserve the fertility fertility ability. I will do this to ensure the endometrium is intact. It's right. But when do I think it can use the three ways of the operation procedure. It's a good way to do the hydrodissection. We can distinguish which layer is more clear, right? Yes.
Okay,
I
let's move
agree.
on
I
to the next.
agree. I also do that. If the women want to preserve the endometrium. Okay.
Okay, let's move on to the next one. From Dr. David. He's asking if the patient is still the desires of pregnancy, is microwave ablation safe? From the table, trans cervical approach is not for fertility.
Yes, really. And about 1 years ago, I still have the same the same concept with you. If the women with the fertility desire, it's the transcervical is safe. But actually, I show you I can tell you it's safe because the recently a paper published, it said totally 30 about 30 women receive the transcervical operation and then have the 37 pregnancies after the operation surgery. I suggest that if you do the transcervical operation, we need to keep a distance away from the endometrium at least 1.5 centimeter. And but you need to tell your patient maybe this time the operation efficacy may be not so high because it can only ablate 70 to 80% of the adenomyosis lesion. So you need to tell them before surgery. But if keep this rule, we need to away from the endometrium. We still can protect the endometrium. It's feasible and effective. Really, yeah.
Okay, and the
Okay.
next one goes to Professor Mohammed again. He's asking, are you doing ablation of subserosal tumor as well?
Submucosa as well. I prefer to do the laparoscopic ablation, but I will remove the submucosa myoma at the same time. I will not do the operation of submucosa because the submucosa tumor, uh, if necrosis occurred and the drop inside the abdominal, we still need to remove it after all. So I will do the laparoscopy myotomy and the operation, the intramural or the submucosa myoma at the same time. So I
Okay.
won't, yeah, okay, thank you.
Okay, the next one is from Dr. Lucio. He or she is asking, is possible transvaginal approach like RFA?
Yes, just almost the same as I ever did these two procedure and the microwave and the radio frequency ablation. I still using the transcervical ablation, almost the same. Just only the degree because the radio frequency can create only the 80 degree, not the 100 degree, I think. And the radio frequency create the ablation machines to slower than not so fast compared to the microwave.
Okay, and
Okay.
next from Professor Mohammed, from transvaginal approach, are you using coaxial technique with endocavity ultrasound probe?
Okay. So you plan to do the actual technique? Really? Yeah, actual technique. I agreed. Yes. So I
Yes.
just now I show you we use introduce the firstly and confirm the predicted rule, and then we insert the antenna, right? Yes. But I would suggest that if you do the abdominal, I would suggest the abdominal echo should be maybe more suitable for this procedure. We can clearly and we make a bladder distended, and we can see the very clear view of the uterus. Yes.
Yeah, can I talk? Thank you very much for a very nice discussion, a
Yeah.
very nice lecture. But my question was for coaxial technique for transvaginal. So, are you using this, or is there any help for coaxial? Because, for example, for bony lesion, we are doing coaxial, so to avoid heating to the extra tissue. So, for the same concept is for transvaginal. Is it helpful with the coaxial technique or no need? Thank you.
讲的是 哎，东你听得懂吗？
对，他就好像意思是说，你经阴穿刺的时候用不用那个套阴超的那个同轴的
是啊，
那个探头，超声阴超的那个探头？
英超的是不是？
对
所以他习惯用这样嘛，是不是
对，就只是在经阴的方式下。
？We have to wait, right? I totally agree that we have to wait to do this transcervical procedure. The first one is I'll show you just now. I about 2 years ago, I still do the same procedure with you using the coaxial technique with the transvaginal echo to do this the oocyte retrieval, almost the same. But now I change it to use the transabdominal ultrasound to see the uterus is very very clear. Yeah. The one disadvantage of the transvaginal the ultrasound is you can maybe for the most gynecologists the abdominal ultrasound view may be more comfortable for the practice. Yeah, not every not every gynecologist are very familiar with the transvaginal echo view. Okay.
Okay, and the
Now,
next one also from Dr. Nino and Daisy. They're asking, can you show us the photo or steps of the fixing mechanism during transvaginal ablation?
fixing mechanism.
During
You
transvaginal.
mean maybe I can show you some. It's actually very easy because but okay, how to say that I can show you the photo and have a brief explanation. I'll show you. Just now, I still answer the last question. I'll show you. The 2 years ago, I also do the same procedure with you using the transvaginal, the guiding set to do the operation. But now I change it to do the abdominal. I'm more comfortable. It's okay. The both way is okay. I agree. And now I will show you how to fix in the okay. You can see that the first one I used to the Alice. I prefer to use Alice or hook to to anchor the cervix, and then I do the coaxial needle introducer into vagina, and then insert the antenna through the introducer into the uterine cavity. Yeah, but firstly, we already infuse about the 500 milliliter of normal saline into the cavity, so we can see what. 对哦sorry, I don't. Sorry, just now we can see the first one, the fixing mechanism. Maybe you mean this. Firstly, we do the I like to do the Alice or the hook to anchor the cervix, and then insert the introducer. And finally, we use the antenna into the uterine cavity to begin ablate. And but we have infused 500 milliliter of normal saline into the abdominal cavity. The cul-de-sac, we can see the many fluid accumulate inside the cul-de-sac, and then we begin to ablate. Okay. Okay. Yeah.
Okay, so I think we have the very last question. How do you do follow-up? How do you monitor it?
Okay. Follow-up, I prefer to do the follow-up every 3 months, and semi-yearly beyond 1 year. And everyone I will give. I'm a urogynecologist, so I will give them the many different questionnaire, quality of life questionnaire, and especially in the such as the uterine fibroid. the quality of life questionnaire, and the PPAC to evaluate the blood loss, and the VS score, and the UDS6 is one question and talk about the quality of life, the urinary symptom, and the sexual function. I also evaluated before and after the operation. I think the sexual function should be improved after surgery. Okay.
Thank you. I think without more questions, we're going to the end of today's webinar. And also Dr. Nino, she's asking for your email.
Okay, email I will share. Okay, I can give you email. Let's discuss anytime. Any question, it's okay.
Okay, so we will forward Professor Long's email to Dr. Nino after this webinar. So thank you all for joining us today. I'd like to extend our heartfelt thank you to Professor Long for sharing his invaluable insights and expertise, and also all these very active questions and Q&As. And of course, thank you all for joining us today, and we look forward to see you next time. And take care. Goodbye. Good night.
Okay.